I'd like to invite Dr. Rajiv from Dr. Mohan's hospital in Chennai. Dr. Rajiv is a retina specialist. Waiting for them? Should we wait for them? Okay. So I should just go? Does it matter where?
So this is Dr. Nama Hamel from Google, and she will be talking to us about her journey from being a doctor to an AI researcher in preventing blindness. Welcome to Nama.
Thank you. Good afternoon again. My name is Nama. I am a glaucoma specialist by training. And at Google, I work on a team that applies machine learning to medical data, specifically medical images. These are my financial disclosures. Now, you might be asking yourself, what is an eye doctor doing at Google? I've been asked that question many, many times, and for good reason. So the truth is that my journey to Google, or my journey from a clinician to a clinical machine learning researcher at Google, started as a complete coincidence. So I am not an engineer. I have not written a line of code. I have no background in machine learning. And I actually did not know that Google was doing anything that has to do with ophthalmology. A friend of mine who was doing a project at Google, he's an emergency room physician. He came up to me and asked, he said, you know, I heard they're looking for ophthalmologists. Can I give your name? I said, sure, no problem. So I joined. At the beginning, what they asked me to do was just look at photos and say whether there's diabetic retinopathy or not. But really, very quickly, fairly quickly, I realized two things. One, that machine learning has the potential to revolutionize the way we practice medicine and improve healthcare, the way we deliver healthcare. And the second thing was that we have to do this as a joint effort. Doctors can't do this alone, and tech companies can't do it alone. I want to talk to you today about three things. One, what machine learning actually is. Two, what is the potential of machine learning to transform the way we deliver healthcare and empower doctors. And three, basically what every ophthalmologist needs to know about machine learning, because machine learning is coming. So let's start with a quiz. Look at this fundus photo. Tell me what you think. Does this patient have diabetic retinopathy?
No.
No. Okay, good. That's an easy one. Even a glaucoma specialist can answer that. Is this person a smoker? Why? You said no? Why? Sorry? I couldn't hear that, but. Oh, okay, you can't tell. Okay. Some people sometimes say, some doctors sometimes say yes or no, and the reasoning goes around the blood vessels, right? They say, oh, the blood vessels, the arteries are narrow, so highly or more likely that this person is a smoker. How old is this person? Sorry? You have to guess. Okay. Again, of course we don't know exactly, but you can say somewhere between 40 and 60 because the reflex, the sheen of youth is no longer there, but there are no age-related signs yet. Is this a man or a woman? Yeah, okay. This is where everybody laughs. Okay, we'll get back to this. So machine learning is all around us, whether we are aware of it or not. This is machine learning. This is machine learning under very complicated, unforgiving, real-life conditions. And this is machine learning. And if you're not aware of or not familiar with the game Go, it's a board game that has relatively simple rules, but very quickly gets very complicated because look at the size of the board. Now, many people thought that it will take years until a computer could beat a human in a match of Go. And in 2016, DeepMind's AlphaGo algorithm beat Lee Sedol, the world champion, at a match of Go. This is also machine learning. Machine learning is not only in complicated and sophisticated applications like self-driving cars. It's in things we use on a daily basis, again, whether we are aware of it or not. It's when we search photos, unlabeled photos in the photo app, when we use text-sensitive email reply suggestions, or when we use a translation app. So what is machine learning actually? And the truth is, when I joined Google, I thought I knew what machine learning is, or artificial intelligence, or at least I thought I had a good idea. But actually, as I started working with Google, I realized that I have no idea what it is, and that machine learning and clinical practice, or teaching machines to do what clinicians do, doesn't translate one-to-one. So this is a document that I put together for Google when doctors come and join us, explaining what it means and how it affects what we do at Google. So machine learning is a type of artificial intelligence that enables a computer to learn how to perform a task without being explicitly told how to do it. Deep learning is a type of machine learning that has been proven very effective in the past 6 years, 5 to 6 years. Now, you might have heard of different types of machine learning. There is supervised learning, unsupervised learning, reinforcement learning, a bunch of different things. Everything I will show you today and talk about today is supervised learning. So what does that actually mean? It means that if we want to train a computer, teach a computer to detect that a photo has a panda in it, using traditional computer vision techniques, we would have to tell the computer up front what are the features of a panda. A big white face, black ears, black eyes, black nose, and then the computer could apply those rules and tell that a photo has a panda in it. Using machine learning or deep learning, all we have to do is give the computer the photo and tell it it's a panda. Give it a label. We call it a label. So the photo with a label. And then the computer figures out the associations in the data by itself. So the key insight here is that it is now easier to program computers to learn than it is to hard code them to be smart. And why do we apply machine learning or deep learning to medicine? Deep learning is very useful in situations where we have a lot of data to look through and we don't have enough people to do it or enough expertise to do it. And this is exactly the situation in diabetic retinopathy. And you'll hear a lot about diabetic retinopathy later in this session. So I'll just give a very quick overview. We have over 400 million people with diabetes in the world today. All of them need their annual screening for diabetic retinopathy. There aren't enough doctors to even check or screen all of these people. And even in diabetic retinopathy screening programs where they take a photo, there aren't enough doctors to look through all these photos. So the team at Google that I joined, they were thinking, and this was done before, regretfully before I joined, they were thinking, could we train a machine learning algorithm to detect diabetic retinopathy in a fundus photo? So they collaborated with 2 big hospitals in India, Shankar Nethralaya and Arvind. You'll hear about that as well. And they had 130,000 images of diabetic patients. They built a labeling tool, and they onboarded 54 ophthalmologists to look through these images and grade them on the ICDR diabetic retinopathy scale, from no diabetic retinopathy to proliferative diabetic retinopathy. And they used all this data to train a model that can now tell whether a fundus photo, if it's shown a new fundus photo that it's never seen, it can now say whether a patient has diabetic retinopathy or not. And this paper was published in 2016. And the algorithm actually turned out to be very, very accurate. The AUC here is 99%, and it's on par with ophthalmologists. Additional work done on the same data improved the algorithm, and it is now on par with retina specialists who are the gold standard for diabetic retinopathy diagnosis. So building on that work, our team thought, what else can we do? We know that the eye is a window to the rest of the body, that the eye is the only organ where you can see the capillaries, the axons, the actual inside of the body with, from the outside. So they were thinking, maybe we can predict risk for cardiovascular events just by looking at fundus photos. Now, as you can see, thank you. So this paper, as you can see, did a great job in predicting risk factors for the cardiovascular disease, blood pressure, hemoglobin A1C, and a bunch of other things. And it also, for the overall cardiovascular risk or risk for MACE, major adverse cardiac events, it achieved an AUC of 0.7. Now, this is not amazing, but it means there's some signal that we still need to work on. So if we go back to the quiz from the beginning, is this person a smoker? This algorithm could detect or could predict whether a person is a smoker or not with an accuracy or with an AUC of 0.71. And if you look at the photo on the right, you see that grayish hue on the gray photo. That is how or where the algorithm is looking to make its prediction. And it looks like it's somewhere around the vessels. Now, don't forget, this is a single example. This is not what the algorithm was looking on in each and every one of the photos. What about age? The algorithm can predict age with an absolute error of 3 and a little bit years. This is pretty nice. And if we look at, again, the explanation or attention mask is what we call it, all that green on the gray, it looks at largely on the vessels, but not only. And then is this a man or a woman? And this is the mind-blowing finding of this paper. The algorithm could predict self-reported sex with an AUC of 0.97. And if we look at the example, we can see that the algorithm is actually highlighting both the macula and the optic nerve in this specific example. Now, the story of this finding, okay, why would anyone try to predict self-reported sex or sex from a fundus photo? This was actually a task given to an intern who joined the team and had to learn how to train machine learning models. So she was given this task, and nobody expected this to come with anything. And she came back and said, well, actually, I'm getting a good prediction. And the team was like, no way, you're doing something wrong. Go back and do it again. And she went back and did it again, and the accuracy went up. And the more she worked on it and the more everybody looked at it, the accuracy went up and up and up. So it's not that this is a useful or clinically useful prediction. There are easier ways of finding out whether a person is a man or a woman. But this is an example of the power of machine learning or the power of deep learning. And to tell you the truth, when I joined the team, I was thinking, okay, I am here to teach the computer. And the computer will learn to imitate me. It will try to be like me. But it will never be as good as me. And it will never be better than me because I am the expert, right? And it's only imitating me. But when I saw this, I was like, okay, this is big and this is powerful. So our take-home message number 1 is that deep learning is a very powerful tool. So we have a nice algorithm that can predict or detect diabetic retinopathy in fundus photos. What will the algorithm say when we show it this photo? What do you think? Sorry? Malignant melanoma. Okay. What about this? Papilledema. End-stage glaucoma. What did we train the algorithm to detect? What did you train it? I told you about the algorithm. We trained it to detect diabetic retinopathy. So what will it say when it sees all these? No diabetic retinopathy. And this brings us to the second take-home message. The algorithm will only be as good as what we show it or as what we teach it. So if we train it to detect diabetic retinopathy, that's what it'll do. And if it sees something that doesn't look like diabetic retinopathy, it will say no diabetic retinopathy. Okay, so that's something that's very important because this is very different than how humans think, right? We look at a photo and we immediately know if it's normal or abnormal, right? And if it's normal, good. If it's abnormal, we start thinking, okay, what's abnormal about it and what's the differential diagnosis? That's not how the algorithms are trained, unfortunately, right? They're trained to do a specific task, and that's what they know how to do. Okay, a few more examples, and we can go quickly on this, of things that we do that are not diabetic retinopathy and are built upon the diabetic retinopathy and cardiovascular work that I showed you. This is a work that was published in December in Nature Biomedical Engineering, and this is a model that can actually detect anemia and hemoglobin levels from a fundus photo. So if you see the black arrow C curve is from age and gender or metadata, demographics only, and when we show the algorithm the photo only, it actually is much more accurate. Another example is work that actually was published last month, and this is an algorithm that was trained to detect diabetic macular edema from fundus photos. But when we trained the algorithm, we gave it a photo, a fundus photo, and the label, remember the panda, the label for the photo was driven or was taken from an OCT scan. So the model learned to look at a fundus photo and basically say what's in the OCT. Okay, and it's doing a great job. And the nice thing about it is that the model can extract three-dimensional information from a two-dimensional image. And think about a screening setting. If we put a relatively cheap camera, right, because fundus cameras are much cheaper than OCTs, we can get OCT level accuracy from fundus photos. So this is very promising. Another example, this looks very similar, but it's completely different. This is an algorithm that was trained using the AREDS data to predict progression to neovascular AMD. So again, the model was given a fundus photo, and the label was, this person developed neovascular AMD a year later. And the model was trained to predict that. The model accuracy was about 0.7 or 0.77. Again, it's not amazing. It's not as accurate as the diabetic retinopathy algorithm, but it means there's signal. Anything above 0.5 means there is some signal in the data. So in general, if we think about machine learning, there are two buckets or two main things that machine learning can do for us. One, it can automate repetitive tasks. It can do things that we can do, but are either not good use of our time, or there aren't enough of us, there aren't enough eye doctors in the world to do them, like screening. And it can also find new signals in the data, things that we can't do, predict progression, okay, for example. So just a few words about what it means to train a model. And again, when I said at the beginning that everything that, or what I think every ophthalmologist should know, this is one of them. We need to be able to understand what it means when someone comes and says, I trained a model. So when we want to apply machine learning, there are three things we need to take into account. We need to have an objective. It should be useful, something like detecting diseases in medical images. We need data. Typically, we need a lot of data. We want it labeled. We want it to be fair. and we want it to be representative of the task that we're trying to achieve, or we're trying to teach the model to do. And we need a model for continuous optimization. So for example, if we want to train a model to say whether a photo is of a cat or a dog, we need lots of photos of cats and dogs. We need them labeled correctly. So a cat is a cat and a dog is a dog. And then we show all of these to the model, and it learns when it sees a new photo to say whether it is of a cat or a dog. In the same manner, we treat medical imaging machine learning models. Let's say we want to know if a photo is of a glaucomatous or not. We take a lot of photos, we label them as glaucoma or not glaucoma, we show them to the model, and hopefully it learns to do this task. More? Sorry? Cut it? Okay. Okay. Just one more thing, very practical. Once we train a model, we want to know if it's working well, right? If it's doing what it's supposed to do. So we have a development set, and we test the model on a test set. We got an AUC of 9.5. It's very high. Is that enough? No. The numbers are not enough. We want to see that the model, or we want to evaluate the results qualitatively, because the model can actually learn things that we didn't expect it to learn, like the notch from the camera, or things that are very, very distinctive, like PRP scars. We also wanted to generalize. So the fact that we have a model that worked on one test set is not enough. We want to see that it works on multiple data sets, from multiple camera types, from multiple populations, from multiple geographic locations. We want to see that it's not only validated clinically, but also see that it generalizes. And the missing piece, or the one important piece that you'll hear a lot about, is we want to see that it actually works in the real world. So the fact that you train a good model, an accurate model in the lab, is not enough. It doesn't mean that it will work in the real world. You have to see how it integrates into workflows in the clinic, in different places, in different clinics, in different countries. So just in conclusion, deep learning algorithms are a promising tool for ophthalmology. We need high quality data. We want to see that it validates and it generalizes. And again, we as ophthalmologists need to know what machine learning is, and we need to be ready for the prime time when it's coming. Thank you.
No, from the photograph. This is from the photograph.
Yes, the model only sees
it just
the
sees
pixels
the
of the photo. It doesn't see any metadata.
Doing retina and doing things, I cannot say this is a male or
Absolutely
female.
true. So
like to know, because you know Google has everybody's data.
Yeah.
So I still have my skeptical mind doubting the differentiation male and female.
No.
Is there any clue? I like to know, or we all like to know. We all are
No, it
people.
is absolutely true. I'll just tell that because this study, when we started 2013-14, there were initial set of images which we gave. It was all anonymized data, and only two things were given: gender and retinal image. And then I had a chance 2013-14, I think, to go to Mountain View, and they told me photograph is detecting 95% accuracy diabetic retinopathy, 99% gender. So this is something, but again, we can have after the talk, we can have this discussion. Yeah, because it basically looks at the vessel's disc macula. I think that's something which
and another thing, we as ophthalmologists never asked ourselves, because we never needed to tell if it's a man or a woman looking at the fundus, right? Maybe if we had to, maybe we would have done it.
Fine. So thank you, Dr. Nama. We have 4 more talks. After that, we'll have a discussion. We can have it during lunch. Definitely, Dr. Nama very rightly said that deep learning is today, it is not something for future. We are all seeing it every day, and it is coming in our healthcare. I'll request Dr. Raj Lakshmi. She will be talking about demystifying the use of AI in diabetic eye care screening. One good thing is that there's been a lot of evidence which is created from India, starting from the 2016 article Even Dr. Natarajan, who made the recent JAMA ophthalmology article, lot of work on AI has emerged from our country. This is something to be proud of.
Good afternoon, everyone. Thanks, Rajiv, for inviting me for this session. I have no conflicts of interest or financial disclosures. See, once we know what our burden is, then we will have to find out what our solutions would be like. So that's where we need to know that we have 415 million people with diabetes, and American Diabetes Association and WHO insist that every person with diabetes is a potential candidate to develop retinopathy, and every person with diabetes needs an annual retinal examination. Why bother about the world? Let's look at the Indian scenario. The IDF Atlas of 2019 says that India has 77 million people with diabetes. The CURE study and the SN-DREAM study have shown us that the prevalence of retinopathy is roughly around 18 to 20%. That is, 1 out of every 5 people with diabetes in India is possibly having retinopathy. So that translates to about 15 million people having retinopathy in India. But imagine, our concern is not these 15 million. We are bothered about the 60 million people who still don't have retinopathy yet, but they need to be screened. So our target is actually to screen 77 million people with diabetes once a year, lifelong. Is this humanly possible with the use of ophthalmologists alone? Very often, what we find, I'm from a diabetic center, and I'm a practicing ophthalmologist in a diabetic center. What I often find is that there is no awareness among our patients regarding retinopathy or diabetic eye disease. Our patients know, they get scared about diabetic foot, diabetic kidney disease, but they are really not bothered much about the eye. Basically because retinopathy has a very long asymptomatic period. And basically the primary point of care for any patient with diabetes is their physician. So unless the physician insists that the patient needs to undergo a retinal examination, the patient is not going to go and meet the ophthalmologist. And so majority of the time, say if a patient has to go to Arvind or Shankar Netralaya, they would only go when they are symptomatic. They would not be otherwise going to a eye doctor for a retinal examination. And so basic mode of screening for retinopathy has now become fundus photography or imaging of the retina. So if the patient wants to get themselves screened quite early, it has to happen definitely at the physician clinic. The physician can definitely have a direct ophthalmoscope, examine a patient, or he can refer to an ophthalmologist if it's a polyclinic kind of setup, he can refer to his friend ophthalmologist for a fundus examination. Or if he owns a fundus camera in his own clinic, he can have a technician who can take the photograph. But then the photograph has to be graded by an ophthalmologist or a trained grader. Or there could be vision centers to which, or NCT clinics where such cameras can be there. But again, it has to be graded. And here is where artificial intelligence would play a role. This is about the rural scenario. The rural people don't even have access to specialized diabetes care. It is not just screening for retinopathy alone. We need to be screening for all complications of diabetes because all of them are interconnected. So we have a mobile telemedicine van where the van has an ECG machine. It has a biothesiometry where you can check the BP, blood sugar, HbA1c. You can take a fundus photograph, etc. Again, if you go to a village and you have to then wait for the fundus photographs to be seen by an ophthalmologist who's in an urban center, centralized grading center, this again, when will the patient know after the images are taken? So in all these scenarios, artificial intelligence would be a useful solution. So what is artificial intelligence for us to understand as ophthalmologists? Basically, it is a technology where the software is able to recognize certain specific patterns in high-resolution images. And once you teach the software by giving it, say you show that multiple mild NPDRs, it then recognizes that it is mild NPDR. Or you just show it multiple moderate NPDRs, that's how it tends to recognize. And once it learns, then it manages to grade DR by itself. So this is where Google, INAC, IDX, Meteos, many other companies have trained the software for image recognition, and now we find that the results are so good that it's as good or even better than human experts. Of course, IDXDR is the first AI device to get US FDA approval. So this is our practice. This is one of our clinics in Tanjavur, where as a part of routine screening, one of our patients underwent fundus photography using a Remedio fundus on phone camera. And you can make out, anybody there can make out the huge fronds of new vessels on the top of the fundus, of the disc, and you can see macular edema in the left eye. And the patient's vision was 6/6 and 6. The patient was asymptomatic. And even when the photographs were sent to me for diagnosis to Chennai, the same time it was uploaded for AI diagnosis. And you can see the AI diagnosis, it correctly predicts it as PDR and DME, CSME present, and it is referable for, to the ophthalmologist. So the diabetologist had an instant diagnosis of PDR even before I could send back the diagnosis to him. So the asymptomatic patient was immediately referred for FFA, OCT, and he underwent PRP immediately. So this is thanks to teleophthalmology and artificial intelligence. So majority of these diabetic clinics, say if there are 10 patients seen every day, only most of them will only be having no retinopathy. So these patients need not actually be seen by the ophthalmologist. It's a no retinopathy. Only patients with moderate NPDRs or the severe NPDRs and PDRs with severe DMEs need to be actually immediately referred to the ophthalmologist. So the AI predicts all these quite accurately. These are a battery of all the various studies done so far, where it shows that the sensitivity specificity is very high and predictable. So AI has been proven in different ethnic populations, showing a very high sensitivity and specificity, both in retrospective and prospective studies. This was the study done at that clinic, where it was a single clinic, just 1 month data, about 200 patients, where we found that the sensitivity specificity for any retinopathy, sight-threatening retinopathy or referable retinopathy, with a very high sensitivity specificity. So we just definitely, in fact, after the study, our physician started asking me, ma'am, why do you still have to report? Why can't you still, we have the AI? That's what, because the physician wants instant results. What are the advantages, so we see, of this AI system? The speed, the consistency. Say if I grade the system today, and I grade the same thing tomorrow, I could call it moderate today, I might be labeling it as moderate to severe tomorrow. I may say DME is present today. I may say there's probably no DME tomorrow. A drusen may look like an exudate to me today and may not be looking at it tomorrow. So this, and the accuracy of grading. And of course, Nama was mentioning about the prediction that it can make. See, again, using systemic data and longitudinal set of images, it can predict who is likely to develop sight-threatening retinopathy in the future. And it can enable the retinal specialists to actually focus on treatment. And it is going to be very useful for screening large number of people with diabetes. But when we know about the strengths, we also need to understand the limitations. A machine, as Nama rightly said, can miss what a human reader may notice. Say if there's a green here and it says no retinopathy, and everything looks green and fine, but whereas I as an ophthalmologist may think that there is some asymmetrical cupping and possibly needs a field test, which the machine may miss, and it can give a false sense of security to the patient. Okay? And it can't overcome, unless the images are clear, high-resolution images. Sometimes if the photographic quality is poor or dense cataract, a proper fundus image is not possible, then the AI algorithm cannot overcome these limitations. So what are the challenges? We have used it in the research mode. Shankanetra, Arvind have used it in the research mode. And real-time deployment of these models in clinical practice in India definitely is a challenge of 2020. So we need a regulatory approval for use of this AI. What are the liabilities in case there's an error in the diagnosis made by the AI algorithm? And again, we have to definitely ensure that all the images are anonymized and there's no question of any privacy or privacy protection laws. We need to be very careful now with the government being very stringent about data sharing and things like that. So, and of course, there are many optometrists and graders. They always have a fear. Now with the AI, they may even lose their jobs. I don't think that should be a concern, because with the number of people with diabetes in India. So this is a broad classification between human grading and artificial intelligence grading. Of course, manpower in India is not very expensive like the Western world, so we still have enough number of graders and we have enough number of people with diabetes. So I think artificial intelligence will definitely play a role where we need a quick, consistent, accurate ability to handle mass screening, etc. Of course, so that more quality time, by when the artificial intelligence can help with the screening, the ophthalmologist can spend more quality time with the treatment, etc. So these are some of the publications which have come from India. You can see this is the publication. We had a study done. Dr. Natarajan did a study. Aravind and Shankanetralaya have done a real-time study. And we have also seen that basically even now a diabetic clinic also did a study. So if we really want to reduce the burden of diabetic retinopathy in India, it has to be a combined effort. First would be lifestyle modification to ensure that the diabetes is controlled. Use some simple equipment, low-cost equipment, so that every person with diabetes is screened. There are multiple low-cost fundus cameras available. Use AI as and when needed, when large number of people need to be screened. And I would like to conclude saying artificial intelligence definitely has a very high accuracy for detecting referable DR. It can empower the physician to detect DR with immediate results, and it can ease the healthcare burden. The short time, accuracy, consistency, and scalability make AI in DR detection very promising. And it is not just for DR alone. It is extensible for AMD, glaucoma. A lot of AI solutions have multiple things to offer us. Image quality will be very important to play in the accuracy. AI is not the AlphaGo which will replace the ophthalmologist. It will only be a helpful assistant for the ophthalmologist. Real-time deployment of AI in clinical practice must definitely happen with care and caution, keeping in mind the legal aspects. And we need to always remember that AI will be a helpful tool and not a threat for diabetic retinopathy detection. Thanks for your attention.
We'll take the questions at the end.
Okay. I would like to invite Dr. Rajiv Raman. He will talk about leveraging AI and genomics for better eye care interventions.
Thank you. So we heard from Dr. Nama and Dr. Rajlakshmi the interventions in diabetic retinopathy. I would dwell in few minutes on something which we have been working on last about 2 years, on another place where AI is rapidly striding, that is in genomics, and how it can be translated into a eye care intervention. So actually last few days, this is, I don't know why it is becoming dark, but inside it is written there is machine learning, deep learning has really picked way, and why it has done is because of increase in the big data, the computing powers, the mathematical modeling, the social media, IoT and automotive industry all have really improved. And last decade that has translated into improved capacity of speech recognition, image recognition, motion recognition, and 2020 the buzzword is the natural language processing. And that has really paved way for many of these algorithms. It's not only eye, but if you look at last couple of years, there have been many devices which are based on artificial intelligence, which have got a FDA approval. You can also see there the IDX device for diabetic retinopathy screening. Currently, the applications of AI in retinal diseases is mainly screening of the disease. You must understand there are two different aspects, screening and diagnosis. Screening is somewhere where you go to the community or on a mass screening, and diagnosis is done by an ophthalmologist. It's also helping us in diagnosis in a couple of ways, and it's paving its way the way we manage. Coming to genetic influence, especially on the retinal diseases, broadly we have monogenic diseases where you have one gene which is defective, or complex diseases like glaucoma, diabetic retinopathy, which are called as multifactorial disease, where we know there is an impact of genetic factor also. And the genetic testing, which has also become very common in India today, is indicated in this monogenic disorders today. Looking at only the retinal diseases, currently genetic testing is able to identify nearly 60 to 80% of inherited retinal diseases. So 80% of our patients, if we routinely do a genetic testing, we can know the diagnosis, and it has got certain implications which are given here. And at Shankanetralaya, we have been using the next generation sequencing, and nearly 85% of our hereditary retinal diseases, we have a genetic diagnosis. Where AI can play a role is from initial, the variant calling or a genetic annotation, genetic or variant classification, and a phenotype-genotype correspondence or a genotype to phenotype prediction. And what I'll be talking more about would be the last two things, which some of the work which we have done, the genotype to phenotype correspondence and predictions. So the correlation is done either based on clinical features, which can be a EMR or a demographic data, investigative tools like autofluorescence, fundus photography, electrophysiology, or tools like OCT. So correlating that with the genetic diagnosis. So this was a work which was done where people tried looking at a most common Stargardt's disease, which has got a ABCA4 mutation. And we know that if a person has ABCA4, we do give him a counseling, don't go to the sunlight, avoid ultraviolet B because it increases the progression of Stargardt's. We also know that these are the patients, definitely you should not give any vitamin supplements because the disease progresses more fast. So a simple way is we do a OCT, and there are a couple of mutations which are common, the ABCA4, the RP1L1 or EYS. So this study actually looked into, can we create an algorithm which can detect ABCA4 mutation the moment we show the retinal, the OCTs. And it again had a training and a test accuracy group, and what you can see, the accuracy for identifying ABCA4 was 100%, very high accuracy. Means if you use this algorithm, put it for OCT, it can tell 100% of time if it is ABCA4 mutation. So these are some of the images. This got published, and there was little overfitting of this model. I'll not go in detail why. Another work which we have been working is with a company called as Skylome, which is again using the OCT and the retinal photographs and the EMR data from the whole genome sequencing and whole exome sequencing, and trying to predict what the phenotype is all about. Also, there is work on genotype to phenotype prediction. Now, I'll tell you example how. So we all know that about 10% of the people who have dry AMD over a period of 10 years, they either go towards choroidal neovascularization or they go towards geographic atrophy. And this was a work which was done in Europe. They tried looking at using all these imaging markers, and even the non-imaging markers, they used some of the genetic markers, some of the SNPs which are associated with AMD and the demographic data, and try to develop a model which can predict where this progression will happen. This is some of the heat maps which this study had used, and it showed a AUC of 0.8. 80% of the time it could predict whether an intermediate AMD will go towards geographic atrophy. However, they found that if you add genetic features, it didn't improve. So this was just based on non-imaging features, that is OCT characteristics. If you add genetic factor, it didn't improve the prediction model. But what I wanted to show, people are using these genetic information now to create these predictive models. This was a work which we did at Shankanetralaya. We were working on this gene called as HERPUD1, which is associated in PCV. And we found that one of these SNP, single nucleotide polymorphism, was associated with treatment response. So when this type of a genetic change is there, it responded well to anti-VEGFs. And we are still working on that, and we have one publication there. And then we thought that why don't we develop a deep learning algorithm that we show a retinal image and it starts telling whether this polymorphism is present or not. And this was a work we did with the NTU in Singapore. and F-score was pretty good. So 85% times we could predict with a retinal photograph this type of polymorphism is present or not. So this is just a example. It can be used in multiple ways, and people are exploring these things. So few examples where the AI has improved the diagnostic capacity from the basic science point of view. So if you talk to any of the genetic people, they use this deep variant which has been developed by Google, which gives a very good, more accurate picture of a full genome. So people are using this in their labs. Just 2 more slides. There is another company called as Deep Genomics, which is working on pharmacogenomics, how the treatment response would be based on the genetic data, again an AI-based company. And Sophia, which has been working on cancer genetics, knowing exactly what should be the best drug treatment for individual patient. So there are a lot of applications. People are trying to explore how deep learning can be influenced in the genetics. Just to summarize, by augmenting the human performance, AI has a potential to markedly improve the productivity, efficiency, workflow, and it's not the strongest of species that survives, not the most intelligent who will survive. It's one who is most adaptable. And I think today in this era, that's what Charles Darwin said, and we as ophthalmologists, we need to adapt to this changing technology, which is very much there, and we will see this more and more in the coming years. Thank you very much.
Thank you. I'd like to invite Dr. Venkatesh to talk about applications of AI at the real-time transaction level.
Thank you, Nama. I think we'll go to some real-time levels before we close the session. Not going to get into details. Now we know the problem of DR and diabetic retinopathy. So we have been doing a lot of work on DR screening, especially in telescreening by tying up with diabetic clinics, where we get information in the form of images to our reading center. The reading center used a program, and the ophthalmologist read the report, and then the report was sent back to the paramedic working in the diabetic clinic, either to refer or not to refer. So this process used to take an hour now, a few years back, till we started working on this project. There's always challenges of having trained graders. Now the retina specialist time in seeing all these images, there's a time delay, and also quite inconsistent. One retina specialist says one thing, the other person says entirely a different thing. So there's always been these challenges, and that's where all these work which has been done in the recent past has thrown a lot of light into the sensitivity and specificity of how AI can work into DR again. So these are some of the areas where we are trying real time now. We are saying whether a primary care physician who's got no or really an average knowledge of grading DR, the model is to upload the image, and then the AI would do diagnosis for referral. And also within our general ophthalmology clinics, where there is a knowledge of DR, but the idea is to upload the image and the ophthalmologist grade it, and the AI also grades this and then shown to a doctor to augment his grading. So this is again a kind of an interface where there will be both accuracy and also a learning behind it. And when we see some of the turnaround time in the telescreening clinic, now with the AI tool, the 1 hour has become a minute now. So I think when we say 1 hour now to some of the deep learning experts, now they would really kind of give a strange smile at us. Now we can do it in a minute. So we are also trying in real life in vision centers. I don't have data on that, but we have been trying out in some of our vision centers where the images were graded by ophthalmologists, and now the AI tool gives an information to the medical professional on the other side to do the teleconferencing. So this is how it works in the clinic. Now after registration, all patients who have history of diabetes get undilated imaging, and then they undergo all other investigations, and then the image and the report is uploaded on the EMR, and then the ophthalmologist does a dilated final examination, and both the gradings are again compared before a final doctor again sees them. So if you see this data of those 3 centers where we are really working now, to validate this from July to September, period in 2019. The total number of images is almost 700 here, 293, and in the base hospital some 3,400 plus images. And this is one important thing. All doesn't look rosy sometimes because you have quite a significant number of ungradable images between these three places. But there are some reasons related to that. If you see the general units in the base hospital, that is at Aravind Madurai, had close to 30%. But here, most of the patients had mild to moderate to even significant cataract. So cataract is again kind of hinders getting you an high quality image, so it cannot grade sometimes in those images. And between these two clinics, if you see, the difference is again because of one center was dilating all the patients after checking the chamber, the other center was taking non-mydriatic. Again, the non-mydriatic center had a little bit higher of ungradable images. And if you see, there's the mismatch also because it is ungradable. Some of there is a mismatch in the exact DR level, slightly higher in the units where there were a lot of cataracts again. Between these two centers also there was a difference. So the interesting part is the referral pattern also changed depending upon how the pattern of dilatation worked. There is a difference in the way they referred also. The diabetic center 2, which dilated all the patients, referred almost 18%. The center 1 referred 10%. And in the main hospital, it was close to 16% cases were referred to DR. And as I said before, many of these images were ungradable because of significant cataract. And all images which were ungradable by the AI were referred to again ophthalmologists to see if they had any retinopathy or significant retinopathy. So when you see the data of the two diabetic clinics and in the main hospital, the referable DR that the AI tool missed, if you see, it's roughly 1%, who are supposed to be referred, but the AI missed. It's like 7 in 700 patients, which is 1%. In the second center, it was 3 in 293, which was again 1%. In the base hospital, it was 21 of 3,400 plus patients. Again, it was 1%. So this looks good, but we'll have to see on removing the number of patients which is ungradable from this, then the percentage would slightly go up. But again, I think with a lot of iterations and also improving the imaging and getting a better image in cataract patients would improve and reduce the number of ungradable images. So these are all the challenges which we are seeing in real time now, environmental challenges. We have a lot of human challenges, including operator skill. When there is a turnaround, people change. You need to train them to do the right way. And sometimes you have patient-related factors related to compliance and also to convince a patient for imaging at every visit, so that would bring in an extra benefit to them in the screening. And other factors which I'm sure we can definitely make better and better with technology and training. And also single field image is always an issue unless you have some changes in other areas. It may impact on your feedback. And further in the evaluation, I think now we are looking at how the volume works, the dynamics of it works between patient screen before and after the AI application. And the simple turnaround time itself is giving us a good idea that the volume is drastically increased with the AI tool now in practice. And the difference in detection rates with and without AI is one thing which we are closely looking at. And more importantly, I think it's the sight-threatening diabetic retinopathy is very important, and we need to really look at the detection rate with and without the AI. And all this would definitely have a lot of improvements coming up in the near future to make this technology better and better. So I'm sure it's very promising from the way some of the work which has been happening in the lab to the setting in the bedside, where we are really testing it out in some of the diabetic clinics, vision centers, and in the base hospitals. There is a significant improvement in the efficiency and the time taken to give the reports, and also to help some of these patients to be managed better. Thank you.
Thank you very much. It was really a very nice example how in real time AI has been used. We have been using mainly as an assistive read for the anterior segment doctors. I think in paucity of time we will not have questions because the next session people are waiting now. But during lunch, please feel free to ask questions to any one of us. Thank you very much.